Hello everybody and welcome to the second session of the resuscitation about which is part of the half academic days of the Qassmi Hospital for Women and Children Neonatal Perinatal Fellowship Program. I hope you've listened to the first session, and this is the second session. My name is Yahya Ithawi, and I'm the nominated Neonatal Perinatal Medicine Fellowship Program Director. So we were talking in the first session about, and we've reached to the necessary equipments. We've talked about the warmer and the pulse oximeter, and one of the most important also laryngoscope with different blades. And this is for preterm and late preterm, but also for extreme preterms. For preterm and term baby, we need blade size 0 and 1, but for also extreme small size babies, we might need 00 blade. And make sure that you have extra batteries and the laryngoscope is working and the light is okay. And also we need different sizes of ATT necessary for various weights with internal diameter of 2.5, 3, and 3.5 millimeter. And it's better to have 2 or more of each of these ATTs. We need a list of medications such as epinephrine with concentration of 1 in 10,000. We need normal saline and sodium bicarb, although it's not necessary at the current practice. We might need or not naloxone, depending on the situation. It's better to be not part of the resuscitation, but based on the request of the physician. We need various size umbilical catheters, 3.5 and 5 French size. We need various syringes of 1, 3, 5, 10, and 20 ml. We need also various gauge needles, 18, 25 gauge. We need T-connectors and stopcocks and various other sets used for IV. We need a transport incubator, and it should be equipped, and it's better to be combined resuscitator and incubator, and it would be wonderful if the same bed can be moved to the NICU to be used. Should be battery operated and should be able to provide heat source, and should have a portable blended oxygen with provision of temperature control and humidity. We always necessary to connect the baby to oxygen if need to admission and he's in need for oxygen and or provision of positive pressure ventilation, especially if it need for more than few breaths. The pulse oximetry can be applied immediately after birth, and it is very successful in getting the oxygen saturation and the heart. However, sometime to pick up it might take time, between 60 and 90 seconds. And there are certain situations that might have no reading, such as poor cardiac output, or sometimes you have an artifact such as in presence of light. You need an ECG, and the leads of ECG usually can be applied a little bit quicker than pulse oximetry. And however, the resuscitation team need to be aware that sometimes ECG may gives you a pulseless electrical activity of a very depressed infant. An end-tidal CO2 is a good tool to monitor and confirm the position, and instead, in addition to the ATT position. However, now there is a growing use of the ultrasound for that. When you arrive, the resuscitation team arrive to the delivery room, they should be checking for the presence of the transport incubator and whether that incubator is plugged, warmed, and full availability of full oxygen supply from the wall or from the oxygen tank. Before starting resuscitation, even if they know each other, it's better to introduce him yourself to the team and introduce others to the obstetrician and involve anesthesiologist. If the mother is awake and the father is awake, it would be wonderful if you present yourself. While you're taking a little bit of data, especially if that's the first time you encounter, or if you can review the data, if you already know their patient, ensure again that the radiant warmer is on and that all the dryness and warmth blanket are available. Turn off the oxygen or oxygen blended and adjust the flow to somewhere between 5 to 8 liters per minute. Adjust the oxygen to desired initial needs, so which is room air and term, and maybe up to 30% in preterm baby. Test your flow inflation or self-inflation bag and make sure that the pop-up valve are controlled. Be sure of your sizes of the mask for fitness. Make sure that your laryngoscope is working and the light is on. And prepare the appropriate blade, one for full-time, 0 for premature, and 2 zeros for extreme premature. Make sure that you have an ETT with appropriate size for premature babies, which is 3.53, 2.5, although for in NRP, but most of the time you won't use it, but sometimes yes. Most of the babies need about 13 centimeter length insertion of the ETT. Some people use a stylet and others not, but when you use it, you try to put the tip of the end about 0.5 centimeter above the distal end of the ETT. If the clinical situation suggests that an extensive resuscitation will be needed, remember to do the following. Prepare umbilical catheterization for venous access. Draw and prepare 1 in 10,000 epinephrine and normal saline. And flush these with a catheter and make them ready. Check the potential need for certain drugs and should be ready for administration. Exposure to different fluid and secretion is inevitable in delivery, so one should take care of that. So universal precautions such as wearing caps, goggles, and glasses, gloves, and impervious gown, impervious gowning until the cord is cut and the newborn is dried and unwrapped. During the delivery, the team should be aware of the type and duration of anesthesia because that might affect the ventilation and the respiratory status of the newborn baby. Also, extended maternal bleeding might cause hypotension and hypovolemia and need for volume expander. Presence of conditions such as a nuchal cord or meconium might need an extra step during gestation. Once you start putting the baby on the resuscitator, start immediate period of evaluation, make decision and action. So it's triplet: evaluate, decide, then act. Place the baby on the warmer, dry infant completely but gently. Always remove the wet linens, including those, you don't change the linen above the baby, but also change those below the baby. You have to dry very thoroughly, but generally. Avoid vigorous rubbing or attempt to clean sticky blood and vernix. That's something can be done later. Ensure the baby is warm is vital. Extremely small babies might need extra warming techniques, such as wrapping the baby and the extremities in a plastic wrap or bag, or use exothermic mattresses. Place the infant with the head in the midline position with slight neck expansion. Avoid extensive flexion or extensive extension. Suction the mouth, the oropharynx, nurse thoroughly with the suction bulb if there is obvious obstruction. Do not suction if there is no obstruction. Make sure that the patient, if you start need for positive or you decide to use the positive pressure ventilation, make sure that the airways are open and appropriately suctioned. Deep suction and stimulation may cause harm, such as arrhythmia due to vagal stimulation, and should be avoided. The meconium-stained amniotic fluid is present, but the baby is vigilant for increased upper airway obstruction and have equipment. Usually is not necessary to do an extra step, but having the equipment for suctioning is vital. It's vital to assess the baby for need of oxygenation. Now, for the normal fetal circumstances, usually the oxygen saturation is way below the level for normal human beings or the one with extrauterine life. And this, the transition from less than normal saturation to normal saturation sometimes takes time, up to 9 minutes. And the oxygen saturation might goes up to reach 70 to 80 to normal, and this might take several more minutes. During this time, the baby may appear cyanotic, although clinical assessment of cyanosis has shown to be unreliable indicator of actual oxyhemoglobin saturation. So once we need to be aware of that. Now, always remember oxygen is drug, so insufficient or excessive oxygenation might be harmful to your baby. And part of the assessment for the oxygen supplementation need is using the pulse oximetry. There are many studies done around the period of resuscitation to assess the oxygen saturation level in the few minutes following birth. And there is a special targeted ranges to monitor a baby saturation trend from the delivery until reach the extrauterine oxygen level. The best data has been shown by taking the saturation from the preductal right side upper extremity to avoid potentially confounding effect of shunting through the various duct during transition. There are probes specifically designed for neonate, can provide a reliable reading within 1 to 2 minutes or less. The oxygen saturation measurement may be sometimes unreliable to assess the cardiac when the cardiac function and the skin perfusion is poor. It is recommended that the pulse oximetry be available for use in the delivery room. And some of indication for use is when a resuscitation is anticipated. Or also if the resuscitation was not anticipated, but you need to start positive pressure ventilation for more than a few breaths, you need to use it when you can see that there is evidence of possible cyanosis. And when you need to start oxygen, these areas, the presence of pulse oximetry are compulsory. Once the assisted ventilation or supplementation of oxygen use you start to use it, oxygen concentration should be adjusted to achieve the measured preductal oxygen saturation values, and it should be clearly documented within the target range of specific minute specific references, such as those advocated by NRP. The best available references for the oxygen saturation helmet is available following delivery of a term baby at the sea level. Different ranges have been also determined for preterm babies or those for C-section and vaginal routes. Sorry. This table shows range of oxygen target during period from birth until we reach the normal target level of extra-uterine life. And you can see at birth an oxygen saturation of 60% is advisable, and the trend goes up slowly until reach to the extra-uterine life. There is a sequence of intervention can happen and need like a retrograde assessment tool, and the Apgar score are designed to be assessed at 1 and 5 minutes, and that would help to retrogradely assess the effectiveness of resuscitation. However, the NRB guidelines recommend that the baby at term should be assessed for 3 questions. The first question, is the baby term gestation? Or the other one is, what is the gestation, or is the baby preterm? Does the baby has good muscle tone, or does the baby has a poor muscle tone? Is the baby crying or breathing? Now, according to the answer, if the answer is designed in this way, and if the answer is no, then the initial steps of resuscitation should be commenced. It's always vital to remember that most of the initial step of the resuscitation needed in the immediate postnatal period is as a result of inadequate respiratory effort and maybe obstruction of the upper airway. And therefore, all the initial steps should be focused on that to provide adequate airway and adequate breathing. This table showed the component of the Apgar score, which is composed of the heart rate, and it's grade to 3 grades, respiratory rate 3 grades, muscle tone 3 grades, reflex irritability also 3 grades, and the color to 3 grades. This is the end of the second sessions of the academic day of Qassmi Hospital Fellowship Program. And that academic day was about resuscitations, and hope to see you in the third session about resuscitation. Thank you very much. I'm Dr. Yahya Ithawi, and these are some suggested reading about neonatal resuscitation.